trial management of chin and Stokes breathing, and I think cardiologists call this HFrEF, and the LOFT-HF trial. So this is outlined for today. We'll talk briefly about central sleep apnea, what types of central sleep apnea we're typically dealing with. Why do we want to treat chin and Stokes breathing? We'll talk about major PEP clinical trials, the CAMPEP trial, the SERVE-HF trial, and ADVAN-HF trial very briefly, because ADVAN-HF trial is still not published. Went on clinicaltrials.gov and realized that their completion date is supposedly June 2020. But with COVID, I'm not sure if it's really completed. Probably they're still recruiting. We'll talk about what did CAMPEP trial teach us back in 2005, what did SERVE-HF trial teach us in 2015, and what led to SERVE-HF trial failure. There are a lot of theories, and we'll talk about that a little bit. In fact, Jeff Harry was talking about this again in Sleep 2020, so there was something there. You can go on and take a look. And what are the treatment options in patients with HFrEF and chin and Stokes breathing? CPAP, should we use it? When should we not to use it? Other options, positional therapy, nocturnal O2, phrenic nerve stimulation. Then I'll spend about 20 minutes on LOFT-HF. We'll talk about the hypothesis, the design, objectives, eligibility, criteria, devices, protocol. And there were a lot of change of protocol due to COVID and also the study flow. So when we're talking about classification of central sleep apnea, I want to remind fellows, again, there are physiologic central apneas. Central apneas during phase 6 REM is one. It's probably when we're dreaming. We just hold your breath in our dreams, and these will be seen as central apneas, typically during phase 6 REM. We have transitional central apneas, or we call sleep onset centrals. These are typically in stage 1 sleep. As sleep stages deepen, these transitional central typically goes away as soon as you see stage 2 sleep. Post-arousal central apneas is physiological. And you can, of course, have arousals from obstructive apnea. So sometimes you can have an obstructive events and C2-3 central apneas after that. And it can be from PLMS with arousal. It can be from chronic pain, and patient was waking up from pain. It can be from mask leaks. It can be from a GERD. Basically anything causes arousal. It can have post-arousal centrals. I want to emphasize this again because it's important when you're reading a sleep study to put down what you believe patient has. Was it physiologic centrals? I think for fellows and junior faculties, I think it's important to make it a habit, because over the years I've seen these sleep study from outside. Oftentimes I have absolutely no clue what was going on. I think at least you need to put down it's not chin and Stokes, it's not narcotics, and you can put down what you believe you may be dealing with, so that whoever's reading a report knows what's going on. And there are hypocapnic central sleep apneas. Classical examples, chin and Stokes breathing. And you have primary central sleep apnea, which is diagnosis by exclusion pretty much. Stroke-related central sleep apnea. In these patients, you do not have total respiratory cycle length greater than 40 seconds. Typically, they are shorter cycles. High altitude periodic breathing. We're not dealing with it here. And then you have hypercapnic central apnea group with the narcotics-induced central apnea, and as well as neuromuscular disorders, which is some folks will call it pseudocentrals. And then you have CPAP emergent central apneas, and you can have chin and Stokes as part of the picture here, or you can have narcotic-induced central, or you can have physiologic central apneas as part of the picture here. And then you have central apnea associated with endocrine disorder and acromegaly and hypothyroidism and so on. So this is an older way of looking at, especially when you're looking at a sleep study, how you want to address in the report. Of course, we have the ICSD-3 classification of central sleep apnea. You have Chinook-Stokes breathing. You have central apnea due to medication or substance. Classical example, narcotics can be methadone, oftentimes oxycodone, and so on. And a similar picture is, in fact, seeing, I don't have slides for you, is also seeing baclofen, high-dose baclofen for alcohol withdrawal treatment, as well as Xyrem. You can see that in Xyrem. Central sleep apnea due to medical disorder without Chinook-Stokes breathing can be in stroke, multiple sclerosis, cardiac malformation, and so on. Primary central sleep apnea treatment, emergent central sleep apnea, again, you can see this not only after you start CPAP therapy, but also post-tracheostomy and dental appliance and so on. And probably have to do with increasing arousals. And a lot of these patients, you just treat them with CPAP, and after 3 to 6 months, they will get better with time. Sometimes in some patients, there may be a need for ASV, but majority of the patients will respond to CPAP. And then you have high altitude, and there are some pediatric stuff. I don't deal with these. So this is a classical Chinook-Stokes breathing case. This is a patient from 2005. And you can see the crescendo breathing pattern. You can see the increased total respiratory cycle length in this patient, about 60 seconds. You can see the increased circulation time in this patient, about 40 something seconds. Yeah, normally it should be probably under 20 seconds or so. You see atrial fibrillation, in fact, with some PVCs, and you see oxygen desaturation to 86%. Again, there are about 15 breaths in between the apneas, a very classical situation. And you have arousals at peak hyperventilation. So this is a classical Chinook-Stokes breathing. And I want to mention this real quick. This is just to give you background Chinook-Stokes breathing, congestive heart failure. So sleep disorder breathing prevalence is about 50 to 70% in patients with HFrEF. It's not uncommon at all. There are multiple studies showing that. And obstructive sleep apnea is seen 24 to 5% of these patients, which is the prevalence is certainly higher than general population. Central sleep apnea, probably about 25 to 40%. So when you read these studies, some of the studies will say most of the sleep disorder breathing seen in HFrEF patients are central sleep apnea, and some of the folks will say it's obstructive. That has a lot to do with how low the LV ejection fraction is. So in general, the lower the LV ejection fraction is, the more likely you're going to see Chinook-Stokes breathing. And if the LV ejection fraction is not so low, or if you're dealing with the half, the preserved LV ejection fraction, then you're going to see diastolic dysfunction. In both obstructive sleep apnea and central sleep apneas, Chinook-Stokes breathing can increase morbidity and mortality in patients with heart failure. There are a few studies showing that sleep disorder breathing is strong and independent risk factor for recurrent heart failure, hospitalization, and for excess mortality. Now, PAP has been traditionally used to treat obstructive sleep apnea and Chinook-Stokes breathing patients with heart failure, but the effects of PAP on morbidity and mortality are not very well studied and not entirely clear. An example was the CWRU trial in 2015. This was published, and we had to stop using ASV after 10 years. So we always felt that ASV was helpful. ASV was first become available on the market in 2006, and we used it for 10 years. Then we found out that, in fact, ASV was causing problems and was increasing cardiovascular mortality. So ASV, we found that it is contraindicated in patients with LV ejection fraction under 45%, primarily Chinook-Stokes breathing during diagnostic study. And this statement will come out several times during this talk, so that fellows will remember the contraindication. And the beneficial effects have also been reported in medical therapy recommended for CHF, cardiac synchronization therapy, for nerve stimulation, and nocturnal O2. The impact of long-term O2. This is nocturnal oxygen therapy, NOXT, on the prognosis in patients with HFrEF, and Chinook remains unknown. So we really do not have, even though there are multiple small studies, I'll share with you a review article today, and even though there are multiple small studies, but there's a lack of a large randomized controlled trial, and this is why we're involved in this LOFT-HF trial. This is a very interesting slide. In fact, from 2017 from Respirology. This was from Matthew Norton from Australia, and he's pretty well known in the field of central sleep apnea. And this is about progression of congestive heart failure, sleep disorder, breathing. And there are three groups here. I want you to take a look here. There are several interesting points I want to mention here. The first is a lot of time folks for a sleep apnea patient have hypertension and diastolic dysfunction. That is pretty common. And so you kind of progress from obstructive sleep apnea and diastolic dysfunction. I won't really call it heart failure, probably diastolic dysfunction. Maybe progress at a certain time to systolic heart failure. And maybe with time, the LV ejection fraction may drop, maybe from heart attack or something. Then you can end up having or development of atrial fibrillation. Then you can get into Chinook breathing with systolic heart failure with lower LV ejection fraction. But if you look at this, I want you to pay attention to this. Chinook breathing, a classical sleep study. If you see a classical Chinook crescendo, decrescendo, everything classical, it's probably a male patient. It's the classical PSG finding. In fact, in my opinion, I don't see a whole lot in female patients. In female patients, they're always a little bit not so classical, but there is a hormone issue. In fact, there are small studies done on hormones. So male patients have tendency to have central sleep apnea, and hormone manipulation can change that. So I want you to remember that Chinook breathing is extremely common and typically seen in male patients. That is shown in CWRU trial as well. 90% of the CWRU patients are in fact male patients. And heart failure, worse in Chinook. Obesity, probably less a problem. Upper airway, snoring is of course common in obstructive sleep apnea patient. Loop gain increase when you have Chinook breathing. Ventilator control here increase, CO2 decrease, and hypoxemia is less a problem on PSG. I believe this graph, what it's trying to tell us is that in obstructive sleep apnea patient, you can desaturate to 40, 50%. My record was 26% on PSG after 2 minutes of pulse. But in Chinook breathing, you don't desaturate that much. You can go down to 70%, but typically in the 50%, in the 80% range. And work of breathing in obstructive sleep apnea probably pretty high, but in Chinook is high as well. Efficiency of breathing, of course, in obstructive sleep apnea patient with closed airway is not so efficient. So I thought this is a very interesting slide to throw in here, just to, we'll talk about the mechanism of why oxygen help heart failure patient and Chinook breathing patient. So why treating this patient? The reason for treatment is really try to improve cardiovascular outcome, morbidity, mortality, and try to help symptoms. There are different symptoms. Again, for Chinook breathing, if they have Chinook breathing throughout, they are going to have a lot of sleep fragmentation. And I'll show you a case in a little bit. And have some insomnia. They will have problem maintaining sleep, non-restorative sleep. Now, heart failure is important to remember for fellows that heart failure and atrial fibrillation, patients oftentimes, when they have sleep disorder breathing, oftentimes they do not have as much sleepiness. The reason, the thought behind that is because it is thought that is because of increased sympathetic activity in these folks. So they kind of stay awake, at least that's the theory. On the left side, you see this graph here. This was published from Ohio State a few years ago. And after discharge from acute heart failure, you follow patient for a period of years, and if they have central sleep apnea, obstructive sleep apnea, they have worse survival compared to no or minimal sleep disorder breathing, and hazard ratio is about 2. And the rationale behind treating chin and stokes breathing, there are several reasons for that. First is in congestive heart failure patient with high LV filling pressure, with the wedge pressures up, CPAP of 5 to 10 general augments cardiac output in awake patients with congestive heart failure. If you look at small single center trials, there were a bunch of these back in the 90s, follow up for 1 to 3 months, and CPAP attenuated chin and stokes breathing in association with one increase LV-HF fraction. It varies. Small increase of LV-HF fraction, suppression of PVCs, reduction of norepinephrine level, reduction of daytime AMP level, increase of PaCO2, increase of respiratory muscle strength, improvement of congestive heart failure symptoms. So small scale studies suggest that CPAP can be helpful. And this led to the CAMPEP trial. So this study was done back in the late 90s and early 2000, got published in the Journal of Medicine in 2005 by Douglas Bradley from Toronto. And there are a few names that you need to know about chin and stokes breathing. They all will show up here. Naughton is one. Bradley probably is the most important one, and Jeffrey is very important as well. So when you read about chin and stokes breathing, look for these names. So Bradley came up, published CAMPEP trial. This got published in 2005. 10 centers in Canada, 1 in Germany, 258 patients with LV ejection fraction of under 40%, and chin and stokes patient or central sleep apnea patient with AHI greater than 15, and predominant central, over 50% central. 130 was randomized control, and 128 to CPAP group. And the mean follow-up was 2.2 years, maximum about 5 years. If you look at this graph on the left side, the vertical is the transplant-free survival, and we have time for enrollment, from enrollment. And you have the control group and CPAP group. And for CPAP group, you can see there's in fact higher earlier mortality trend in the CPAP group. This study, in fact, was terminated early, partly because beta blocker was introduced during this period of time. And that changed a lot because they had a hard time hitting the primary event endpoint. And they then figured out their initial estimation, the original estimation of the patient's number is no longer accurate, and they need a whole lot more patients. They figured that they need to terminate the study. So the study was aimed to see if CPAP can help morbidity, mortality, cardiovascular function in heart failure patient if they add it to the standard medical treatment. It's important to know that CPAP use was only 4 hours. Maximal CPAP is not high, it's only 10, and average about 8 to 9. But the conclusion was that CPAP can attenuate chin and stokes breathing. HI can drop from 40 to 19, about 50% drop, improve oxygenation. There's a slight increase of LV ejection fraction, about 2%, lowered norepinephrine, and increase 6-minute walking distance by 20 meters, if I'm correct. CPAP did not affect survival, quality of life, or hospitalization. That's the bottom line, the outcome. The primary endpoint was not reached, but there are some benefits to it. Jeffrey argued that there may be CPAP responders and non-responders, and a post hoc analysis was done on CAMPEP study. So if you look at the left side again, it's transplant-free survival, and you have the time as horizontal axis here. So the line with the star is the CPAP responder, where the AHI can go under 15. So there are about 50% of the patient are CPAP responders, and AHI can be reduced to 15 after 3 months. And these folks have better survival. So the CPAP responders, in fact, experience a greater increase of LV ejection fraction of 3.6%. This is shown on the right side, the right side graph, at 3 months, and significantly better transplant-free survival. So this is pretty much the conclusion of ChemPep trial, the 2 studies, giving us some idea how to treat these patients. But before ChemPep trial, in fact, in 2001, there was the first article talking about ASV. This was published on the American Journal of Respiratory Care Medicine. And this is talking about how different modes or different potential treatment, how it affects central sleep apnea. So if you look at central sleep apnea, the hourly index is somewhere around 40, 30 something. And with oxygen, you can cut that to half. With CPAP, you can cut that to half. And with bilevel ST, I want to emphasize this. This is not bilevel. Again, I've mentioned to the fellows, the bilevel without a backup rate can worsen central sleep apnea because it can cause more hyperventilation. You have to add a backup rate. So this, in fact, is bilevel with backup rate. And also ASV. You can see ASV when this was first study, you can see that it really helped control central apnea index extremely well. And this is what's happening. It's in the same article, and you can see that the Chinook-Stokes breathing after you put patient on ASV, you basically normalize breathing. Of course, this is just maybe 3-4 minutes, but again, it's showing you that this is ASV can be quite effective. And let's come back to this patient of mine from a while ago. And I first saw this patient back in 2006. And this patient was on auto CPAP device, and all of a sudden around Christmas of 2005, failed to use CPAP again. And when I saw this patient, I got this patient another sleep study. And you see what happened was that this patient developed atrial fibrillation probably around Christmas 2005. And all of a sudden, this guy was a patient with obstructive sleep apnea. All of a sudden, patients start having a lot of Chinook-Stokes breathing. And this is like what we were talking about in an earlier slide of comparing obstructive and central. So this patient was obstructive. Turning to central sleep apnea, a Chinook-Stokes breathing pattern after probably conversion to atrial fibrillation, worsening of congestive heart failure. So this patient, eventually I put a patient in the hospital and tried to fine tune CPAP, then ASV became available. And this is how he was doing on ASV. You can see patient's breathing was much better, and you can still see some hypopneas labeled as obstructive, but they are really central hypopneas with a tiny little bit desaturation, but you can see the sleep is a whole lot better. So with the ASV device, and there were questions whether these devices may help us with cardiovascular outcome. So there were 2 trials organized. One is CWRU trial, the other is HFrEF trial. So CWRU trial started from 2008. The data was published in 2015. They used the ResMed VPAP Adapt SV device. It's a first generation device. A little bit different from what we use now. The first thing is that EPAP is a fixed EPAP. The second thing is the minimal pressure support will have to be 3. It cannot go down to 0. So with this device, and the study design is multi-center randomized interventional trial, and AIM, again, is just like a ChemPep trial. And they were looking at LV ejection fraction under 45% with predominant centrals. The Advent HF trial, as mentioned, is probably still ongoing, supposedly completed in June, and it started was in 2010. And as estimated completion date in June. The difference of these 2 trials is that obstructive sleep apnea patients were included, and in CWRU trial, those are excluded. So you can have predominant obstructive sleep apnea. So in other words, maybe complex sleep apnea included here. So, in fact, when CWRU-HF trial result came out, they did look into their study to make sure patients are safe, and they did not find any red flag. So the study was continued. And the other difference is that they use Respironics Advanced BiPAP Auto SV device, which is the current device. If you order Philips, that's what you have. And the principal investigator is Douglas Bradley. So what happened in 2015, and all those folks who practice sleep medicine long enough will certainly remember this. We received a letter, a field safety notice email from ResMed on this date in May. And we've used ASV for years and control central index extremely well. What they found, they reported in email, was that no significant difference in primary composite outcome of all-cause mortality or unplanned hospitalization was identified. The alert was really on the cardiovascular mortality, which increased on the ASV arm with an absolute annual mortality rate of 10% versus 7.5%, which is a 33% increase of cardiovascular death. And this is a great concern. And excess risk appears to be driven by outpatient deaths, likely sudden cardiac death, and increased risk seems to be independent of perceived benefit from the device with no worsening of clinical symptoms or need for hospitalization prior to the event. And with this, ASM in 5 days issued an email warning on a few things. The first thing is new patients at risk. That is LV ejection fraction under 45%, primarily central solution, should not use ASV. It's contraindicated now. The second thing is we're asked to go back and identify all the patients with chronic heart failure with reduced LV ejection on ASB device and stop them. And it was a pain. We had to, in fact, go through all the sleep lab data and the EPIC data, trying to figure out whom we need to stop. It took many nights for me to figure that out. And then I also mentioned before, put patient on ASV, every patient should be assessed for congestive heart failure, probably should get LV ejection fraction and an echocardiogram just to make sure. So these were changes back in 2015. And in September, the survey study was formally published. There were 1,300 patients in 91 centers in Europe. Again, I mentioned 90% male. The default ASV setting was EPAP of 5, pressure support of 3 to 10. The median is about 10 over 5, and the goal was to reach adherence of more than 3 hours with HI reduction to 10, under 10. And these are comparable groups. You can see that Epworth is not high in these patients. AHI in the severe range, central amnea index about 50%, less than 50%, but this is central amnea. The overall central AHI proportion is about 80%. And minimal oxygen saturation, again, as I mentioned, these patients don't desaturate to 40, 50% typically, unless they have obstructive sleep apnea at the same time. ASV was affected. The baseline AHI was down from 31 to about 6, 7. Central amnea poverty index down from 25 to down to about 3, 4. So it's very effective in controlling central events. In the primary endpoint, we look at primary endpoint. They're really not much different. P was 0.10. We talked about primary endpoint. There was really not much difference. But if you look at death from cardiovascular causes and death from any cause, there was a difference. If you look at confidence interval, it's greater than 1. So it's statistically significant for all causes in cardiovascular mortality. No change of Epworth or functional measures. There was no obvious benefit of that. One of the problems is compliance. If you look at compliance, these are from 2 weeks, 3 months, all the way to 5 years, and compliance basically just dropped with time. And if you look at this area on the left, in the red box, under 2 hours and under 1 hour, even in 2 weeks, there are 24% of the patients usage under 2 hours. And when you're hitting 5 years, there are about 36% of patients using ASV under 2 hours. So the compliance was a major problem, of course. In these big trials, we learned that patients were really not too compliant. The main concern, I'm not going to go into details of these graphs. The main concern when you do subgroup analysis, the main concern is LV ejection fraction under 30% and primarily central apneas. The question is what to do. So the first question is what happened. The second question is where do we go from there? So in 2015, we're all very puzzled. We had a hard time trying to figure out what to do then. One of the questions is Chine-Stokes breathing protective in patients with heart failure. In 2012, Norton published an article stating that Chine-Stokes breathing may be in fact protective, and he had a lot of physiological argument there. But practically, the concern is really what happened here and what may be the alternative treatment that we have for HFrEF patients with central sleep apnea. Should we avoid all PAPs or should we continue CPAP? And does the brand of ASV device matter? Does ASV setting matters? Some of the question we still don't know the answers and what to do with patients with Chine-Stokes breathing, but LV ejection fraction greater than 45%. Diastolic dysfunction patient, diastolic heart failure patient can still have Chine-Stokes breathing. By the way, I do want to mention that it's less common, but it's still possible. How about complex sleep apnea patients? How should we treat obstructive sleep apnea patient with congestive heart failure who are the high-risk group? So the thought was that the potential explanation that ASV may be bad, maybe there are hemodynamic disadvantage, maybe these folks were volume depleted already because we're trying very hard to control with medications, and the decrease of cardiac output from using these devices may have decreased the preload and cause more problem. Or maybe there's some sort of vagal imbalance, maybe sympathetic activity somehow increased because patients were uncomfortable in sleep with ASV device. Maybe this precipitated arrhythmia, and maybe the cycling nature of positive airway pressure may have caused some sort of cardiac remodeling, or maybe there are electrolyte abnormalities, acid-base metabolic alkalosis, maybe respiratory alkalosis, and so on. And maybe Chine-Stokes breathing may be protective. This is again argument from Norton. Maybe it's like he described it as climbing a hill. When you're climbing a hill, you need to stop here and there just to rest your muscle. Maybe it's something like that, or hyperventilation may increase and expiratory lung volume and oxygen store, maybe lung inflation, somehow promote vagal tone and reduce sympathetic activity. CWRU just published an article a couple of years ago arguing with this point. And intrathoracic pressure swing may be acting at additional cardiac pump. So there are some theoretical advantages here. And maybe there are other explanations, like 40% patient not using ASV may be really more problem. So CWRU recently in Sleep 2020, and he had this argument. He said, we really don't know the answer, but he again raised the question, maybe there are ASV responders and ASV non-responders. And so far, there's no subgroup analysis done or post-hoc analysis done on these patients. And he was questioning why. Because the argument is here, these are the red boxes here. So if you look at AHI, at 48 months, when you look at a range, some folks AHI go down to 0, but there are still folks with AHI of around 40. And if you look at central apneas, the central apneas, central events percentage was initially 80%, was down to 40%. In some patients, that basically means 40%, that basically means that initially you have more central, now 4 years later, you have more obstructive. And if you look at minimal oxygen saturation, some of the patients are still having SpO2 nadir of 67%, meaning they have significant obstructive sleep apnea untreated. Remember, these devices have a fixed EPAP, and they were fixed at 5 during study. So maybe their obstructive events were inadequately treated. And if you look at the time under 90%, oxygen saturation to T90% or T90, it dropped from 460 minutes down to 280 minutes, but they are still under 80 minutes for a lot of time in some patients. So he argued that we really need to have to figure it out whether there is an ASV responsive group, but that has not been done so far. We cannot be interactive, but I think I'm going to run out of time here. But if you look at this, so what is going on with this ASV titration? This is not part of the CWRU trial, but if you look at this is one of his patients. This patient's EPAP was maxed to 15. If you look at EPAP. If you look at IPAP, it was maxed to 30. So if you look at the bottom, this is the pressure swing that you see. The machine was delivering pressure. The problem is that patient was not getting the air when you look at C flow. And if you look at chest and abdomen at the top, there was no movement for a long period of time for about 1.5 to 2 minutes. So what is going on here? I think Nishan mentioned an article last year or earlier this year about glottic closure. Now, Jeff Harry called it obstructive sleep apnea. I think it's basically glottic closure when pressure goes too high and patient close the glottis and you don't have flow going in and you don't have any pressure that you don't see any expansion of the chest and abdomen because there's no air going in. And what's happening is the oxygen saturation drop with time as a result. So he argued that when you have a fixed EPAP, the pressure support may go to the max, and that may be causing problem. And when it's becoming uncomfortable, folks basically just stop using ASV, or patient will drop their oxygen saturation if they continue to use the device. So he argued that may be a reason. We really do not know. But how should we manage these patients? So you have to optimize the guideline to write to medical therapy. I think positional therapy is extremely important. And we mentioned ASV is contraindicated in this specific population. CPAP may still be reasonable to use if you can control the HI under 15, even though we do not have further data, but it probably makes sense. Now, alternative to acetazolamide, I know Kingman has a few patients. I don't have any patient on acetazolamide. And you can do combination. And now you have free nerve stimulation and remedy. But I know we do not have at UH and at a VA. I tried to get our EP folks interested in this a couple of years ago, but none of them are interested. I want to mention rostral flow shift, which is proposed by Douglas Bradley. He has been talking about this for 15 years. And basically, if the heart failure is not under great control, if you have a lot of ankle swelling, if you have 4+ ankle edema, what's happening at night is when patient lie down, the flow is going to shift. Where do they go? They can go to the neck and upper airways, soft tissue, and cause more obstructive sleep. Or they can go to chest and cause pulmonary congestion, increase wedge pressure, increase chemo sensitivity, and then patient can get into the Chinook-Stokes breathing, hyperventilation, and central apnea cycle here. So getting adequate medical treatment is extremely important. But I believe, and there are several treatment options. I'm not going to go into this. Theophylline, we just don't use it, even though it can decrease central apnea index, but it can potentially cause arrhythmia, so nobody uses it. And acetazolamide can still be considered, but you have to watch for the acid-base change. So this is a patient of mine. I want to show you this graph. If you look at on the right side, there is classical Stokes breathing. You have crescendo, decrescendo. The total respiratory cycle length is about 60 seconds. The circulation time is beyond 30 seconds. So you have a Chinook-Stokes breathing patient here. But if you look at the left side, the hypnogram, this was Code and Paula Smith here. So there are one brief REM period early on, a second REM period. If you look at before the second REM period, oxygen saturation was fine and patient was doing all right. All the blue vertical lines, these are all central apnea. Why do you all of a sudden having a lot of central apnea? If you look at bottom, it's very simple because patient was sleeping on the back. So in supine sleep, you see so much sleep fragmentation. If you look at the top, you have so much sleep fragmentation. And if you pay attention, you will see when you read sleep study, there are a lot of positional component in patient with chin and Stokes breathing. And study, in fact, there are a couple of studies, I want to quote here, the summary is here. The patient with non-positional central sleep apnea had more impaired cardiac function. So if someone has very low LV ejection fraction, it may be non-position, but if you optimize their medical treatment, they may become positional. Then you really should try to use positional therapy, in my opinion. Try to help these folks out because lateral positioning is associated with about 50% reduction of AHI and hypoxemia. So I think it's an important thing to do, and it's fairly easy to do. I'm not going to go into phrenic nerve stimulation, but it was back in 2017, and you have to put a, EP will have to do this. You have to put implant the device, and the lead is going to go to right or left brachiocephalic vein and left or the left pericardial phrenic vein. So that phrenic nerve is right next to it. You can pace the phrenic nerve. I think many of you have seen this. This is the first half is without. The second half is when the phrenic nerve pacer is turned on, and you can see the breathing is getting better. And this was the 2012 study published, and central apnea is improved significantly. The ODI improved as well. The arousal index improved as well. I'm not going to go into this. And oxygen therapy can help as well. It can lower AHI, central apnea index, sleep fermentation, and level of overnight hypoxemia. Can potentially increase exercise capability, sleep quality, and quality of life. So in small scale studies, these have been shown. So there was a nice review article on Sleep Medicine in 2016. If you are interested, you should look into this. So they look at oxygen trials in heart failure and sleep disorder breathing, and there's improvement of AHI. Typically, but there are issues with these studies. The first thing is small group of patients, and some of them only with one night study, many of them with one night study. So the longest term was 12 months, and oxygen typically 2-3 liters. And you can drop AHI by about 50% overall. The range of drop goes from 30 to 80%. So these are a lot of limitations, mostly single center, lack of control, many one night study, unknown chin and Stokes duration. There's probably heterogeneity there. And some of them are mixed with obstructive events and various study design. And this is to look at improved ODI and T90. And you can see that they are significant, that ODI typically drop down to single digit, and there will be significant improvement of oxygen saturation as well. One of the things I put there, just try to find a place to put this here, and oxygen in obstructive sleep apnea patient has been shown to prolong duration of respiratory events, but this is not seen or not reported in chin and Stokes breathing or mixed events. So what's the mechanism? The mechanism is when you use oxygen, you increase oxygen store, you decrease oxidative stress. Just look at the far left side. There are too many things there, but it decreases oxidative stress, it decreases myocardial hypoxemia. It attenuates the hypersensitivity of the chemoreceptors, and it decreased respiratory drive, damping the response of hyperventilation, and it improved blood gas as well. So if you look at the far right, I put down a few points here. Hypoxia amplifies controller gain and reduce the intrapulmonary gas stores of oxygen. And nocturnal oxygen can stabilize the breathing pattern by reducing hyperventilation, change chemoreceptor sensitivity, and can attenuate hypoxia, which is a known contributor to sympathetic overactivity, ischemia, pulmonary hypertension, and vascular dysfunction. So overall, from the small scale study, you can say that it's a potential treatment option. It's less effective than ASV in controlling AHI, we know that, but it's equivalent to CPAP. And it, in general, give you about 50% case may improve alongside with 50% drop of AHI. It does improve ODI and T90. No apparent impact on LV ejection fraction. There are a couple of studies showing that there are some small improvement, but some of them don't really have a control. BNP level, no change in some of the studies, and effective sympathetic tone have contradictory findings because I think there was one study showing that there was really no change of ventricular arrhythmia. In randomized control trials is needed. So this is LOFT. This is the full name of LOFT, impact of low flow nocturnal oxygen therapy on hospital admission and mortality in patients with heart failure and central sleep apnea. And the study hypothesis is that oxygen can reduce all-cause death, life-saving cardiovascular intervention, and hospitalization by 20%. That was the study hypothesis. And it's a phase 3 randomized double-blind sham-controlled trials. So we give patients sham oxygen or sham concentrator providing room air. Outcome measures will be measured for up to 4.5 years, average 2.5 years, 30 to 50 recruitment sites desired across the United States and Canada. This is the dashboard from May. Even in August, still the same. We're only having 24 active sites because all the VAs are pending central IRB approval, and Boston VA is working on that. So we have 24 sites up to this point. The latest number is, I think 33 were randomized. And this study really has been going on for quite a few months, and we're fairly slow, and part of the problem is COVID. University of Pittsburgh did it best. Metro recruited one case, and we're here in May. We were approved for starting a study, but so far our coordinator left, and we need a new coordinator. So there are a lot of things going on right now. So the objective is very similar to SERVE trial. So there is composite endpoint. And we're also looking at cardiovascular events, the specific mortality, patient-reported outcome, quality of life, functional status. There's going to be subgroup analysis looking at chin-to-nose breathing, what is showed basic assessment, what is showing on the sleep study, the LV ejection fraction, level of hypoxemia, AHI, circulation time, loop gain, arousal threshold, and early change in ODI in response to oxygen therapy, and so on, and gender, and so on. So these are the objectives. And the composite primary endpoint is very similar to SERVE trial. It's time to first event of any of these, like cardiac transplantation, LVAD, resuscitation, so cardiac arrest and shock because of ICD, implantable ICD, and so on, admission and use of IV diuretics and so on. And their second endpoint. Initially, exercise capability is part of that 6-minute walking test, but recently this was removed, probably because of COVID-19, but this was removed. So exercise is not going to be assessed. Quickly going through inclusion criteria, adults, again, this is revised. LV ejection fraction was 45%. Now is 50% because we are not recruiting patients. So right now, it's up to 50% criteria. Still, age will have to be over 15 with more than 50% central events, including hypopneas. New York Heart Association classification 304 or 2 with one of the following. So at least one hospitalization within 24 months prior to enrollment, or increase of BNP, increased pro-BNP, and ED visit with heart failure exacerbation within 12 months with IV diuretics. And they have to be optimized from medical standpoint or with best tolerated therapy. And they have to be stable without adding new class disease-modifying drug within 30 days. One of the problems is the long exclusion list. And there's a long exclusion list. If someone's on CPAP or predominantly with obstructive sleep apnea, they will have to be excluded. They have to use oxygen. They have to, at baseline, they have to be excluded. Severe COPD patients and so TIA within 3 months. So there are a bunch of things that we cannot include a patient. And right now we don't, so there are a few things that are changed. The other thing is initially the plan is to titrate oxygen, but now we're no longer titrating oxygen. Everybody gets placed on either a fixed 3 liters of oxygen or 3 liters of room air, pressured room air. And we don't have to see patients right now. Phone call is fine and virtual is okay. The device used for this trial is Nox A1. Nox is Nox Meadows Iceland company. So if you look at this patient left lower corner, you have a device and you have a watch-looking thing with pulse ox. The most important thing is kind of interesting. There's a wire that going across forehead. And if you look at EEG channels, so there are eyes, there are EOGs, and there are 2 front channels. And there's one in the center of the front head here. And you have EKG, you have pulse ox, you have nasal pressure, and you have 2 respiratory effort channels. And when this is done, it will be uploaded to the sleep reading center and it will be scored. And then we can decide if patient is eligible. And by the way, there's one change of criteria I forgot to mention, come back a little bit, that is at left lower corner on this slide, clinical sleep studies completed within 12 months can be used. The EDF file will have to be sent to the reading center. And randomization is 1-to-1. And the active arm is nocturnal oxygen of 3 liters per minute. The control arm is 3 liters room air. And this is the right lower corner is the Everflow concentrator from Philips. And it has a capability of real-time ongoing monitoring of airflow rate and user time for this study. And initial study was going to use this device called oxytone. Oxytone measure PPG from ulnar nerve at the wrist. But I tested it out in May, and it's just very difficult to get it registered right. And I think there were a lot of data issues, and folks, if you put it on and it moves in sleep, and then you lose the signal. But it can measure oxygen saturation, actigraphy, heart rate, and temperature. It does not give you any AHI, and just it's a pulse ox. So for this study, we're trying to recruit from cardiology clinics, heart failure clinic. We're trying to recruit from inpatients as well. We just have to follow them up in 30 days, make sure everything's fine. There's no change of a new addition of class of disease-modifying medications. And at UH is Michael Zacharias. At the VA is the co-PI on the cardiology side is Jose Ortiz. And we need to recruit from sleep practitioners as well, either from clinic or when you're reading a sleep study. If you see Chinostrokes breathing patient, you look at LV ejection fraction. If that is under 50%, and we will take that patient, then we'll pre-screen them. The goal is really to have 50 patients with sleep studies, and hopefully 1/3 of them will be eligible. And the goal is to recruit 858 patients, and we're very slow right now. We're only 33 patients after a year. And whereas each center is supposed to recruit 4 patients a year. So this is the study flow. And so clinically, we try to figure out if a patient is meeting the inclusion-exclusion criteria, then we get a study, or there may be qualifying clinical study in the past 12 months. And if they are meeting the sleep study criteria, then we see them at a clinic or do a virtual visit. Then we randomize them into 2 groups with 3 liters of room air or 3 liters of oxygen. We'll follow them at a clinic at 6 and 12 months, and at 1 month, 3 months, 9 months, and 18 months, we will do phone follow-up. This is the treatment schedule. Each visit, there are a lot of things that needs to be done, but there's a removal of 6-minute walking tests from this list. All right, this is, I believe, the last slide. This last slide is, this is an article published on CHEST just recently. And this is about management approach of chin-to-stirrups breathing in HFrEF patient. So you want to optimize the treatment, medical treatment. This is what I added here, the positional therapy, because Dr. Javahari put it at the right lower corner. But I think it's important because it can be done very easily. And, you know, a slumber bump will do, will cost a little bit of money, but not so much. And if they have persistent central sleep apnea, we don't have phrenic nerve stimulation on the left side in yellow. So we either will have to do CPAP or we'll have to do LOFT-HF. And hopefully we'll be able to recruit more patients. I think it makes sense to support the LOFT-HF trial. And in fact, I'm concerned that we're relatively slow. We really need to try to get more patients in. And of course, if the patient is not a candidate for LOFT-HF, and you can still go back on CPAP. So I think that's probably a better flow for us at this time. So this is pretty much the last slide. We need your help. And please contact us whenever you encounter any patient with LV chest refraction under 50% predominant central sleep apnea. And we're now recruiting. We still don't have we need to get a study coordinator ASAP. VA not yet recruiting, pending VA central IRB. The VA PI is Rawat El Ghul. And Metro is now recruiting. They have 1 patient already. I'm not sure who the contact is. I checked with Dennis, and I think the main contact, the PI, is the cardiologist, if I'm correct. And maybe if Dennis is around, may be able to tell us a little bit more.